Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership in Business podcast, where urologic professionals experience the practical application of business acumen essentials for success in today's dynamic professional landscape. I'm Dr. Jennifer Miles Thomas, and in today's episode, we will discuss organizing a successful practice in the age of working from home and how, looking at the practice, we can adjust today to meet the desires of the new employees, today's employees, while also managing successful operations. Joining me today for the discussion is Nicholas Kirch. He is the program director for the Urology Service Line at Lehigh Valley Health Network and has nursing and healthcare experience expanding over 20 years. Nicholas joined VLPG Urology in 2017 and has helped to expand the practice to 8 locations throughout northeastern Pennsylvania. He has led the practice to unprecedented growth with delivering 5-year annual growth rate year over year of approximately 15% in visits, procedures, WRVUs, and surgical volume. Through a dyad partnership with the Division Chief of Urology, Dr. Angelo Bacala, LVPG Urology maintains the mission and vision of the Urology Service Line with being the leading urologic practice, while also continuing to develop in state-of-art care within the 4 urology centers of excellence, foundation pillars, of the practice's patient care center approach. Welcome, Mr. Kirch.
Thank you, Dr. Miles Thomas. Pleasure to be here today.
Well, thank you definitely for joining us, because we all know post-COVID, the world has changed, employees' expectations have changed. Everyone wants to work from home. So this is a great topic of how do you make that happen in healthcare, where we've all been raised in the society where you have to be in the place, you have to physically be there, even if you're not touching the patient. So can we just start from the very beginning? How do you even determine who can work from home, and how do you develop a process for that?
You pick straws, right, to start.
Definitely.
We gained a lot from COVID, right? So, I think there is, in the industry, we start to, fantasize this concept we can work from home and how can we make this possible? And I think there's studies were being done, and we were partnershiped in some as well with Lehigh University, and looking from an operational standpoint, but never broke it down into specific, what entity could do that, and a lot also affected billing, right? And how could we do this? But COVID happened, it just accelerated, and we got to take some of the positives from this, and it was working from home. And how can we develop that work-life balance? So I think the want was always there, but now we need to fulfill that for our colleagues across the board, and it's for everybody in the practice. It can be from your operational leadership, but that also extends your hours. You look at it that way. From providers, I think that provides a great opportunity. We have significant amount of providers that do like to work from home, and it is possible in urology to do it. You just got to structure appropriate, and then the supporting staff, and how do you align that? I think some of the keys, though, is when you get into the weeds of it, is you don't want to lose sight of that mission and vision, especially your vision. Do you have guiding principles of what you're trying to achieve? And then how do you integrate that in? Because that's going to be your template. It may look a little bit different from a private practice standpoint versus a physician group within a specific health network, because in the network, you may have your specific global mission vision, but you still should have some of your own specific to your service line. So it would impact urology as well as other surgical specialties.
So let's take both. Let's take the local private practice as well as the regional health system. Should we be constrained? Should we think about the other? We know urology across the board. As a subspecialty, it's one of the smaller subspecialties, and we know the lack of urologists and urologic care in many counties in the U.S. So should we be thinking that this is also a way to deliver care for people who are farther away? Not really like telemedicine, but just the fact that, all right, so if we can do it from home, can we do it different hours? Is that something that we should be considering?
1,000%. It is an absolute, advantage point if we can. Telemedicine is great, but we're not the specialty for the classic telemedicine. Mm-hmm. But you provide virtual care, into those outlying regions, especially if you're in that very rural section, I think that provides a lot of opportunities until the patient can get in and have physical assessment. So it can really guide their care. I don't think you're going to be able to manage everything, obviously, through telemedicine and this virtual setup, but it's absolutely, I think, expands our ability to. I think the other parts is as you mentioned with, the shortage of urologists. It's very well documented. The number's not growing; it is shrinking rapidly. We're the second oldest profession, in medicine out there. It's the leveraging your APPs, and I think that's to me, and that's what we have found the best usage of virtual visits is through the APP section. While the attendings are utilizing, those abilities, the vast majority when you break down to like the video visits, and obviously there's some phone visits, but again, that will change over time with CMS, as we continue to monitor, that's how you can really leverage it, is go through the APPs. And that way, then when you're looking at it from a financial standpoint, and where are our surgeons best utilized is in the OR, A, and then B is in office procedures, where what the APPs can't fill. That's where you bring them in. That's where, to us, we've found historically, that's where you can leverage these like work from home kind of situations.
Okay, well, maybe it's helpful if we like break it down per different type of providers. Can you kind of go into that?
Absolutely. So when we look at working from home from a physician or APP standpoint, first and foremost, is knowing CMS regulations, right? Because it's nice that what you're providing is care, but we need reimbursement for the work that we're doing with that. So monitoring that, it's evolutionary, continues to change. Also with your payer mix across the board, and that can be challenging. Who your insurance enrollment's under, knowing those guidelines, then you can start to look at, is it best if I utilize the physician to do this, or is it best to do the APP? Depending on the practice, the physician may, because there could be some needs outside. But if you're looking from an organizational structure, the APP is the way to go, because just the way the reimbursement works, you're not getting dollar per dollar necessarily to begin with, even though if you're RVU based, it may be the same. It's financially more incentivized to do the APPs. We've also been able to develop full work from home days, right? So which is great, and our colleagues really like that. But you have to develop a structure to make it effective. So it goes twofold, right? How are you checking patients out? How are you bringing them back? What is your clinical workflow that's going to fill these visits? During COVID, patients wanted virtual visits, right? We know that at the peak I saw, it was 40% of our visits at the time were virtual. Not sustainable. Clearly, we knew that was not sustainable, but it's doable. And I think 20% was always kind of a MGMA goal to kind of shoot towards. I don't know how realistic it is for urology. 10% is absolutely doable. That doesn't take much, but it's driving patients to have those follow-up visits through virtual. So there's some sell to the patient as well. Is check out. It comes from attending. Hey, you'll follow up with my PA or MP. We're going to follow up in 6 weeks, whatever, for stone disease management. Great virtual visit. Does not need a physical assessment. Same for oncology workflows. I think you could do a lot of that through virtual visits. The first time you're delivering pathology results, doesn't need to be face-to-face. We learned about 3 years ago, maybe 4, that we were, a lot of major institutions had that first visit virtually. We thought that was impersonal, but then we realized we're the only ones that weren't leveraging technology. When we start to relook at it, it makes sense. First time you hear that diagnosis, the patient shuts down. So might as well have that visit. You need more diagnostic testing, and then you can have the face-to-face discussion when you're really going to deliver what is the actual plan of care once you have those last results.
Yeah. So how did you guys go about developing like the clinical workflows? Only if I'm thinking from, let's say, as a chair or practice manager, how do you, are you first assessing the disease types that would be most appropriate and then working through the check-in, check-out, just the strategy for someone who's not doing this at all? Like you said, the default was telemedicine, but now if we're trying to ramp it up or offer new disease states, how do you think about that?
I think hit the nail on the head. It is identifying what disease state makes sense to do it virtually, right? So we've all seen the HIMSS or Roman conversation. They've done a great job. They have fantastic marketing, but they already took a subset of male disease and identify how you can do this on a virtual platform. Any urology practice can mimic that, right? So I mean that gets just one small piece of it, and I guess some of those products per se, it provides great service to folks, but it gives that more private kind of feel, whereas no one actually knows, like, Epic chases you everywhere, or whatever the EMR in your health system is, right? Sometimes people don't want that, and I get that, but from a network perspective, from a practice perspective, we should be able to offer that same level of care for patients that do want that rapport with your providers, things of that nature. But then you begin to expand on it. Everybody wants to just rip the Band-Aid off and start everything at once. It doesn't work well. We all know that, right? So it's kind of taking little chunks out of it at a time. And if men's health is easy. I mean, the classic, with ED and things like that. Stone disease is a great subset to follow. Oncology can be a little challenging just because of the nature of the conversations and the disease set itself, but is absolutely manageable to do it. So it's really truncating what is the standard follow-up visit. The other thing is standardization. If you're going to do something as a practice, if you're an individual private person, you can do what you want to, right? But as that number expands, that's where it gets a little bit more tricky, developing a clinical pathway, and then also having the buy-in of the other providers to follow those guidelines. When you can set that up, then your supporting staff who's doing the scheduling, who is maybe taking clinical triage calls, they're following that same pathway, and then you can move the product through accordingly. And I think that also helps leverage face-to-face, but very, the work from home setup.
That makes sense. Now you've kind of transitioned to the kind of clerical operations. So is there a difference between like office scheduling, surgery scheduling, work from home? Like, can you go into what you guys do and how you set that up?
So I think there's two ways to look at it. There's the generic regular scheduling. You're checking patients in. That's a face-to-face. Is what it is. But there are things that you can develop around that versus pre-registration, scheduling. If you develop an infrastructure, so you could do it a couple of different ways, but you always kind of want to check your registration because you want to make sure everything aligns with the insurance payer, because we want to be paid for the visit as well. And then we also don't want a patient seeing a surprise bill. There's been legislation that passed to help prevent that, but we're held accountable for it. So, and we need to do right by patients. But you could develop some strategy around having folks do that from home. You don't really need to do pre-regs once a month, twice a month. You could set work from home dates for those colleagues. You could, if you're, depending on your practice itself or scheduling, at one point we had a very in the practice, a centralized call center. So all urology calls, all locations came to one setting. If you have the tools, you can set that up where folks are doing, you can have a remote call center, right? So you can develop that. Some colleagues like it, some do not. But for those who do like it, if you have, you can set them up with a laptop, use a program like Jabber or something like that, where they can get the phone call routed to them. They can be set up from their home office and, work their 8-hour shift or whatever they're looking to do. EMR systems, we take it everywhere we go now, right? And you could schedule, the patient from home. Checkout, we do virtual checkout. And we've been doing that for quite some time in smaller offices where we don't have a physical checkout. It falls into a work queue. There's some kind of trackability when a patient comes out through the EMR system. And within 24 hours, we've called that patient, scheduled them for X, Y, and Z testing, their follow-up visits, versus utilizing that physical staff that's not urology based, who does not know how to set up BCG scheduling or things like that, because those visits can't be messed up. It's going to affect patient care. And we've learned to leverage that across the board. So it could be a different office that's doing that, or they could be doing it from home. Again, it gives a lot of flexibility for your office manager and the operational staff. But if you goes back to those clinical pathways, if you have that foundation set up, you can then have your teams follow those next steps. So the next part to it, and this is the easier one of all of them, is surgery scheduling. And this is key, right? So nothing's worse than a surgeon showing up to the OR and things are missed. Unhappy surgeon means the patient's not having the surgery, patients aren't happy, you're doing service recovery as an office manager. And we don't want to see that. We don't want to see patient care delayed. But surgery scheduling historically is face to face. There's a lot of belief. I see this in many other surgical specialties. The physician wants it face to face. That sounds wonderful. It sounds very personal. What I have seen is if you have, and we know this with the shortage of urologists, and you're bringing in additional APPs who are not doing the surgery, they become feeders to the surgeon's volume that's pushing them into the OR. So you've been attending with 3 PAs. That's a lot of people that are going to set up surgeries for that. The APP setting up for the surgeon has a lot of surgical volume for that scheduler to do. So if they're face to face, next thing you know, have a long line out the door to get to each individual person. So actually, a couple of years ago, and we were limited on space, we started doing all remote scheduling within the office because we didn't have the concept you could do this from home. And as years progressed into this, we have for all 8 locations we have centralized surgery scheduling. And it's all done remotely, and then we have schedulers that are for different office, different providers, different centers of excellence, but it's all done remotely, and they're all work a hybrid schedule today. We do. I'm a believer of some face-to-face interaction, that connectivity, making sure you're aligned with clinical pathways. The colleague satisfaction has jumped up tremendously. We track that. We do, anonymous surveys yearly just to see how we're doing. And year over year, our numbers continue to grow. And again, because this is what colleagues are looking for, right? This is that next level of advancement that they can do. It's worked out tremendous. So we're really increased the patient satisfaction, because when you have a smaller site, right, and if that scheduler was out, it could be a week, right? So then you get this big stack of papers. You're still not doing it face to face. Surgeons getting unhappy because they're getting phone calls that they're scared, their OR schedule's not completed yet. So it increased provider satisfaction. And then we're turning around within 24 to 48 hours. We have set metrics to do this to ensure this is achieved for the patient. So that way, within 24 hours or so, they know exactly when they're going to have surgery, where they're going to have surgery, who they're going to have surgery with. And then what are their next steps towards getting to the next step to treat the disease process.
Well, I think it's very interesting what you just mentioned was that in the past, the expectation was setting up the surgery and having that conversation face to face, and us learning how to adapt is this necessary for us? Is this necessary for the patient? Or does the job need to be done in a timely manner? And the answer is it needs to be done in a timely manner. So let's think outside of the box of how we still can deliver that service. So that makes complete sense.
I agree with you. It's changing our expectations. We're slow to adapt. I hate to say it, but we really are. And it's getting to that buy-in. But I think, if we're meeting the patient's expectation on time, we are a service industry at the end of the day. That is crucial.
Well, are there other opportunities from work from home? So let's talk about like clinical operations. Can someone from home do all of the refills, triage? Like what's possible?
Absolutely. One thing is as you grow, right, into multiple locations, is how do you begin to leverage resources across the board, and you're not duplicating unnecessary FTEs and same roles, whereas you can have one person necessarily doing refills for all 8 practices. What is the volume? Knowing the volumes make a difference with it, but when you set up a refill line, and we all have these, you call option 4, right, and then the medicine, who you are, what you're looking for, you could do that from anywhere, right, and setting that up. So it's building some of the organizational structure around that, but you could have them do it from multiple locations. It's building enough work for that clinical colleague to be able to set up that. I think triage works the same as a call room at the end of the day too. Again, it's as long as you have the computer structure set up and set some guidelines with it, it's you could set folks up to do that. And the other thing is if you're looking for education, right? That's a great thing for nursing in general. And having those conversations, you can have that over the phone, and setting up clear, here's what's going to happen after your aquablation. These are things to expect. While it may have went over in the visit, we all know it did. That went out the window. We know that. All we heard is I'm having surgery, and that's it, right? So if you can set up colleagues to do that, then it will decrease some of the backline phone calls through clinical triage and set realistic expectations up front with it. There's a lot of work done in what's it called, MGMA or AMGA, developing some of those new patient partnership models. We've heard a lot about them throughout. And there's, the theory behind it, but then how do you take the theory and delivering? Maybe nursing is the first outreach because you're short clinicians in the practice to kind of maybe triage them, see, okay, this person needs to come in sooner for physical assessment versus this patient could be done virtually. And maybe that's your first point of contact with a clinical team member is through your nursing team. And there's been studies have showing that there's great opportunity in this, and it's improving patient satisfaction, right? Versus if you're short on clinicians and your new patient lead times 56 days. These numbers aren't unheard of, and we see this in urology specifically, as well as other, specialties. If you get that earlier contact, right? Again, work from home position, and then that improves that patient care. So, okay, maybe I can set up X, Y, and Z ahead of time, and then when I come in, I can have more of a fruitful visit with that clinician when that time comes.
Well, it makes complete sense. But how should we even go about thinking about the infrastructure? Like, how do you even set this up? Because it's not that we can just take what we do in-house and just transplant it to someone's home. How did you think about that?
It's a lot of long nights. It is and it isn't, right? I think the biggest thing you need is the computer access, or is it through an iPad, or what is going to link into the EMR? I think that's the number one piece to it, is depending on the EMR setup, is what technology is going to be supported around that. And if if the provider doesn't have it, or if the staff member doesn't have it, then it's identifying what our needs are and then what is it going to take to get there. So do we have the equipment in the office, or do we need to purchase it? Do we have the capital funding for it? Do we not? And I think that, as basic as that sounds, is the key to setting from a technology standpoint up. The next piece of it, I think, is identifying the real-time workflow. How can you move that into like a work queue per se, or how can you track that information so you can take what you're physically seeing in the office today and moving that into a virtual platform, and then that will give you a template to kind of work off for staff to start to work off of, or obviously patient schedule from a clinician standpoint.
All right. Well, there's always the age-old question: how do you track and how do you hold people who are at home accountable? I know we all have seen like the newscast where people had two simultaneous jobs that are full-time working from home. Just how do you put that structure and the accountability there?
So work from home is a humongous challenge for leaders and managers across the board. So, many managers are tracking it, and I think you can put managers in place when you have a pre-established part. You definitely need leaders to get this established, especially getting buy-in to folks and, developing a new program. But kind of mixing that together is, we just talked about the infrastructure, making sure it's there, but developing, measurable deliverables. Like, what is our baseline productivity on checkout, right? So we know those numbers from face-to-face encounters, or we should know those encounters from face-to-face encounters. And you benchmark that should be a little bit higher for if you're working from home, especially if you're doing a checkout, right? If you're doing all virtual checkout, you're going to go through really quick, right? Because the patient's not sitting down, getting comfortable, that small conversation rapport. Phone call is, hey, da 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 da. And I think that you can go much quicker. I mean, I hope you say it better than what I just did. But but I think if you can set that up, it starts to move you in the right direction. I think you also need to develop, if you have the ability, is the analytics piece of it. So if you can start tracking these work queues, we have the infrastructure put in place, and then we start looking at the analytics behind it. Are we increasing visit volume? Are we, getting more surgeries scheduled on a Tuesday when Sally is at home versus when Sally's in the office, she does 7 versus 15, right? And then we start to track that. Once you get in time your baselines through that process, then you can start to develop measurable goals, right? And then how can we improve the process? So I think it's a multifaceted approach, but it is going to help deliver at the end of the day when we can look at achieving your practice working from home, different aspects of it. You're going to improve your colleague satisfaction. It's going to improve provider satisfaction. And ultimately, I think we're going to improve the care for the patients that we're serving.
I agree. So far, everything's been very, very positive. Is there anything that we should talk about that potential is a negative or of concern? Anything with the employee interactions? Anything? Do people feel isolated? I know you guys are actually surveying your employees and you found increased satisfaction. Can you talk about that?
So it is challenging because you're not there for that global oversight, right? So we've all seen that cliche where the manager walks through, everybody's quiet, everybody's like attentively working, and as soon as they leave, the cat's away, the mice will play. That theory. You have that, right? In theory, with people working from home, you have no idea what folks are doing. That's why I think it is important to have that infrastructure. I think patients, if we're not meeting objectives, are very quick today to respond back through service recovery in some fashion or form. And they're more vocal and they're advocates for their care, which is good, right? It keeps us honest. At the end of the day, we need to be. But I think that's a challenge. Have we seen folks that might not necessarily really hit the achieve those benchmarks we're looking for? Yep, it's happened, and I think you got to bring them back into the office. It's not meant for everybody. For those who do it and can do it well, fantastic. I think as leaders we need to support them. We've had colleagues struggle with it, and do they, you don't just pull the plug on it, right? Because if everybody else is doing it but me, it's not fair, right? But is there a way we can help them reorganize, how they're working from home, redevelop something and give them like tips and tricks on how to do that, make sure they have the right tools to succeed, bring them back in, develop that, rework that, and then provide another opportunity with it. The last thing we want to see is, somebody doing surgery scheduling and the grocery shopping at the same time. It's not going to work well. How do you have huddles with your team? How do you connect with your team virtually? Just because we're in different locations, you need to be, you got to be connected at all times. So if I'm overseeing 8 locations today, I physically can't be all of them. My home is in Allentown, Pennsylvania. While I may travel to these locations, I might get there maybe once or twice a month at the most, right? But is having those daily check-ins with your team and continue to maintain, that connection. On providers, I think there's a little bit more, up and up with it, because if you're not having those visits, they're completed. Why, right? Are you in a rural area where cell phone coverage is poor and they don't have the internet? That happens. So you might see more of a decrease, completion rate of visits for the day, but you're also probably having a higher no-show rate too at the same point. So if they're in parallel, it's most likely okay. But if it's not, it starts to have those conversations. What are we doing? And I can honestly tell you, we've had that once or twice with newer providers, and kind of reorienting of this is our priority. We're here for the patient. So while most of it has been good, you're right. There's some struggles, from time to time, but as leaders, we need to work with them. I think the most important time from an operational standpoint for myself is having that partnership with like the chief physician or the lead physician at the end of the day to make sure that you're in sync with one another. And I think that will make sure that successful partnership with all entities of a successful practice are being met.
I agree. Managing expectations. Well, this has been very informative. Is there anything else that you think our listeners should really understand prior to embarking on this new old wave of work from home? Because this is truly what many of our staff are asking for.
I think start slow, right? And have a pilot. It seems basic, but is really the way to go. You can't flip the switch overnight. This has been a multiple years in the making. We're always evolving and changing as new things come up, new technologies are rising. But pick one provider maybe to start with, and go from there.
Sounds great. Well, thank you very much, Mr. Kirch. Thank you for sharing your time and your expertise with us today.
So thank you very much, Dr. Miles Thomas. It's been a pleasure.
Well, definitely. And thank you to our audience for joining us on the AUA Leadership in Business podcast.
Invest in your leadership and business skills at AUA 2024 with the Institute for Leadership and Business track. The ILB track features a total of 7 live courses offered from Thursday, May 2nd through Sunday, May 5th, with additional on-demand content to supplement. Whether you are starting your career, seeking career advancement or professional development, or looking to master the business challenges facing today's urology practice, the ILB track offers education to support your needs and professional growth. To accommodate the busy and robust schedule of AUA 2024 and to ensure that participants have access to all programs in the ILB track, each session will be recorded and can be accessed on demand unless otherwise noted. Visit auanet.org/AUA 2024 to learn more and add the ILB track to your annual meeting registration. See you in San Antonio.